Hi, I'm Dr. Sonia Angell, Bloomberg Distinguished Professor of the Practice at Johns Hopkins University, and I'm really honored to be here today with Dr. Angell Odoms-Young. She is Associate Professor of Maternal and Child Nutrition in the Division of Nutritional Sciences at Cornell University, and also this year's 2026 David Kritchevsky Memorial Lecturer. So, Dr. Odoms-Young, congratulations on a really phenomenal presentation this morning. We all learned so much from it.
Thank you.
As you know, the Dr. David Kritchevsky Memorial Lecture is one of the most prestigious here at American Heart Association's EPI-Lifestyle scientific sessions. It's named in honor of Dr. David Kritchevsky, whose work really fundamentally shaped the way we think about nutrition and cardiovascular disease today. And your presentation, I think, really honored that legacy, but also moved us forward in some really interesting ways. So I want to talk to you a little bit about what you shared with us during this lecture.
Oh, great.
And so I want to start first with helping all of us understand a little bit more about the program, the WIC program that we all refer to. Actually, what is it? So let's sort of start with what you studied.
Oh, great. So I talked a little bit about our work and the work of others to think about WIC as a population health program, particularly a program that's focused on engaging in population dietary change, even though it's at that early life stage. So WIC, the supplemental program for women, infants, and children, was started in 1974, and the idea was to target that population that was at nutritional risk in early life and provide some supplementation. So when it comes to food, so there's a food package, nutrition education, so nutritious foods, nutrition education, referrals to both healthcare and social services. And then instead of just giving that package, the original WIC program gave a voucher where people could redeem that voucher at food retailers in their communities, and also later the WIC Farmers Market program where they were able to redeem a voucher at farmers markets. Now it's EBT that they use at retailers, but since the early years, as well as an extensive evaluation that was done in the 80s, it showed that WIC works. WIC has been able to support dietary change in that early life. And we know with the developmental origins of disease that early period, particularly pregnancy, is critical and under the age of 5. So WIC supports that early life with those nutritious foods, with nutrition education, as well as healthcare referrals. So that really bidirectional relationship with healthcare providers.
So it's a specific program that targets a specific constituency, a specific population. I think a lot of people think of it as maybe a few people benefiting. Actually, how large is the WIC program?
So the WIC program is about 7 million. There's 12 million actually people in the US that are eligible. So there's been several studies to look at how do we bridge that gap. But the WIC program serves about 40% of all infants born in the US. So if we think about 40% of all of the infants in the US, it has a really significant impact. And then studies have shown for every dollar that's spent in WIC, there's about a $2.50 savings in healthcare costs and in social and productivity costs. So it's a large program when it comes to the individuals. Most of our individual level interventions really probably don't serve at the most over 1,000 people, probably at the most. But when you look at a population-based program like WIC that serves millions of people, and this is every month, it has a significant impact on those individuals, as well as society overall. If we think about the fact that the children that participate in WIC actually grow up to be members of society, that early life investment has significant impact for later years.
So this is a really important program reaching a very large percent of the population, right?
Yes.
41% of infants are enrolled in this program in the United States. I think
at any one time.
At any one time.
About 41% of infants, they they don't always go to the end of eligibility, but sometime during their infancy, they participate in WIC.
So that's a very large touch.
Yes.
And you were saying the impacts to the individuals over the course of their lifetime, even though it's a program that's just focused on the early stages, can have long-term implications for those individuals in terms of health and productivity. Something else that you shared with us that I think is a lot of people don't appreciate and that your research really shows is that it's not just those individuals that are benefiting, though. Can you say more about how others in the community may benefit from having people in their community receiving these resources?
Absolutely, because a lot of people don't think about WIC as a multi-level sort of systems change program. The way that the WIC food package is developed is based on nutritional risk in that early population. So there's nutrients of concern, there's nutrients that need to be promoted, but also those to limit. So the WIC food package and also the nutrition education that goes along with that package is very specific and consistent with the dietary guidelines at that time. And so part of what happens when people redeem those vouchers at stores, the USDA requires that there's a minimum stocking requirement. So those foods are not only available for WIC participants, they're available for others. And we have 2 studies that have shown, actually we have more than 2 studies, but 2 studies that I presented when there's a policy change where certain foods are added to the WIC food package, we see a subsequent change in availability. So that food access, that increase in food access or healthy food availability doesn't only benefit the people that are participating in WIC, but it actually benefits the other shoppers that are using those vendors. And we showed in our study after the WIC food package revision in 2006, that those foods that were added were more available in those communities, and that also for some of those foods that the prices were lower.
Fascinating. So that means if I live in a neighborhood where folks are receiving WIC benefits, but they're shopping in stores in my neighborhood, when I go shop in those stores, there are healthier products available for me, and you're finding that those prices might even be lower for me as well.
Yes, in our work, several people, Shannon Zink, a collaborator that I worked with for many years when I was in Illinois, we worked on a lot of those vendor studies, but there's been people all across the country that have found the same result in various states. We worked on the project in Illinois, but there's people in Connecticut and Massachusetts. They've all looked at how WIC and changes to the WIC food package and the addition of those foods can stimulate the retail environment to increase availability for people overall.
So that's a really fabulous example of a very targeted program that has upstream and broader effects on our neighborhoods at large. And as a result, I'll eat healthier and our communities at large will be healthier because we'll have access to healthier foods.
Yes.
That's really, really important research because so much of the evaluation around these programs often just focus on the recipients. Well, that's super important for us to understand the direct impacts. I think oftentimes we don't really understand, measure, or talk about the impacts that it has on the broader community. And that understanding can help us design programs that have greater support, can help support expansion of those programs so that more people benefit directly from them, but that our communities at large benefit as well.
Yeah, I think definitely. And a lot of our food assistance programs were developed in the 70s. So when we think about the creation of new programs, we need to keep in mind what are lessons learned.
Yeah.
We haven't had a lot of programs that have been developed since that time, but if we're going to scale up the lessons learned, whether we create new programs or continue to refine the existing programs, not only in the food security, food assistance space, but in healthcare, the focus on food is medicine. A lot of people think about WIC as the original food is medicine program because there's that food package that people refer to in WIC as a fruit and vegetable cash value benefit, or the food package as a fruit and vegetable prescription. And so all of these types of approaches have really been a part of how we're thinking about food as medicine now. We talk about incentives, we talk about a benefit, we talk about a prescription. So a lot of the lessons learned from WIC about how to have that larger effect can be applied to new programs where we think about an incentive structure to stimulate healthy dietary intakes.
So it really influences not only how we design them, but your work helps us also think about how we evaluate them, which means we really need to build into these budgets not only the program design, but the evaluation, because that's how we can learn from our experiences and improve programs over time. So that research that you've done is just so important. So I want to take a step back because we have a lot of folks that are thinking either now about maybe pivots in their own research careers, or we have early researchers who are looking to you and seeing the wonderful work you're doing and wondering, how do I start on my career? Where would I go? I wonder if I could just ask you a little bit about where you started, and then from there I'm going to talk to you a little bit more about where you think we all should go. So, but tell us, because you didn't start focusing on communities, did you?
No, I didn't. And when you think about pivot, I'm probably a person who loves a good pivot because I started out in doing animal research. I was a part of a program as an undergrad student and worked with my first mentor, Dr. Keith Singletary, to do animal research that had implications for cancer. And I did that work going into graduate school. I went to Cornell for graduate school. And it really was in that almost third year of doing animal research that I said, you know, discovery at the cellular level or in doing animal research is great. But I think I'm a better fit for translational research because that in thinking about how do you translate discovery to society and thinking about dissemination and implementation and scale up. It was difficult to shift because I had a biochemistry minor, toxicology minor. I was mentored in undergrad to be a nutritional biochemist. And so when I realized that maybe I was a better fit, and I think that's important because your understanding changes over time. And I thought we have a good understanding since the 80s about some of these dietary impacts. You know, we just talked about Dr. Kritchevsky's seminal work. A lot of that work was done in the 80s or even before about that fundamental understanding between diet and cardiovascular disease. But unfortunately, as I mentioned, we have continued year after year to fall short of really making sure at a societal level that the uptake of that understanding happens where people are eating a dietary pattern that's consistent with chronic disease prevention. And so as we think about where to go, you know, I thought, okay, well, maybe a lot of my work should shift, which I actually ended up doing, to determine how do we move people from where we are to that next step. And honestly, I realized that I was pretty naive in the beginning because I thought, okay, in the next 5 years of my career, this problem will be solved. Of course, I was 25 and I thought, and now I'm 57. I thought, okay, well, this is going to be potentially a short trajectory and then I would think about something else. But I realized that the importance of moving from that basic science perspective to think about implementation science and dissemination, really worked on a behavioral individual level interventions. And then I did 2 postdocs, one in public health and then in policy during welfare reform. I started getting that fundamental understanding that without policy change, we can't bring these things to scale. But we also have to think about how do we get there? And so people may work across that entire trajectory, but it's important that you understand the implications on both ends. So sometimes the people that are working like me on implementation, dissemination, on policy, they don't always think about what's happening at that basic level. And I think the reverse is true as well. you may be focused on metabolomics, but what's the implications of that for population health? So I think wherever you are in that trajectory, to really have a good understanding of that entire trajectory, even if you don't work on dissemination,
Yeah.
and you're at this very start of that discovery or trajectory, people need to understand on both ends.
So there's lots of space, lots of work that needs to be
Yeah.
done. I think EPI-Lifestyles is a great place where people come together, and if they're not working in all of these areas, they can learn from others who are working in related areas
Yes.
and
Yeah.
achieve what you're describing, which is that knowledge and awareness of how their very specific work fits into the bigger picture and really can advance us all.
Absolutely.
So thank you so much for your presentation today, for joining us now to share a little bit more about your background, experience, your ideas, and your research. Really, really appreciate it.
Thank you so much. And also thanks to American Heart Association EPI-Lifestyle Scientific Sessions.